Welcome to A Time for Change. I'm Kristen Myers here with Jen Rogers. We're off to a bittersweet week here in the United States. Yesterday, the number of COVID-19 deaths surpassed 300,000. But on the same day, there was some hope. It was the shot seen around the world, the first person in the United States to receive the COVID-19 vaccine. You guys can see the video here of critical care nurse Sandra Lindsay. She, as you can all see, is Black, as is the nurse administering the vaccine, and the doctor who then became the second person to receive that vaccine.
All people of color, and as we know, Blacks, Hispanics, and other people of color are suffering in this pandemic, physically and economically, at a disproportionate rate. That fact has fueled our next guest to create a new organization to close the many race-based gaps in healthcare. It's called PTEC, Preparedness and Treatment Equity Coalition. And let's welcome Dr. Benson, who is the Chief Scientific Officer, and Kirsten Axelsen, who is the Executive Secretary. And Dr. Shu, I want to start with you because we're all watching what's happening with the vaccine distribution right now. And I want to see if we can bring a social justice lens to it. Right now, I think people say, all right, you're a frontline worker, you're older, you get it. Everybody else get in line. Is that the right way to go about this in terms of equity?
Yes, thank you. That's a tough question. So as a frontline worker, I'm proud to say that on Wednesday, I'll be receiving my vaccine, given the fact that I work in the intensive care unit. Now, having said that, I also know that a lot of my communities are in populations that are not as well served. Communities such as our Native American population on the reservations. It's a limited resource. So there's definitely arguments to be made that some populations should be targeted differently in the way that we target the elderly, as their risks are generally higher. We know that disproportionately our populations in the Black, Native American, Latinx communities are generally hurt more than our white communities. We know that hospitalization rates are much higher in Latinx, Native American, and Black communities, almost by threefold count. We know that death rates are higher. In our Black communities, we know that death rates account for 34% of the population, whereas they only really account for 12% of the overall population. So given these numbers, personally speaking, I would encourage these communities to be somewhat targeted as we roll out our vaccination.
Kirsten, I want to pick up on what Dr. Shu is saying here right now about targeting some of these minority communities. And I've heard, just colloquially, folks saying that Black folks are going to be guinea pigs, especially if they're targeted and given this vaccine first. I'm wondering how we approach the racial gaps that many fear are going to exist in this vaccine distribution, while also soothing some of those really well-founded fears and anxieties that exist in minority communities about this vaccine.
Absolutely. And, part of the issue is the lack of trust within the healthcare system has yielded a system where clinical trials are not as diverse as the populations that take the drugs. And then you end up with drugs that aren't necessarily tested on the right populations. I know a lot of effort has been taken by Pfizer and Moderna, companies who are developing vaccines, as well as companies that are developing other treatments to increase the diversity of clinical trials. And that's an important step, but it's not sufficient. There are other approaches that increase confidence in vaccination. They include having a physician who is of your same race, has been shown to increase willingness to use preventive care. Being in the communities where people are, making sure the vaccine is getting distributed to the pharmacies, to the health centers, in communities such as the ones that Benson works in that may be rural, but also in urban communities. And again, that the communication is done in a way that is culturally relevant, linguistically appropriate, and that the vaccinators are people who are trusted within the community. There are ways of getting things done within minority communities, but unfortunately, too often, I think we impose a solution that isn't necessarily listening to the people whom we're most trying to reach.
So, Dr. Shu, Kirsten mentioning some of those criticisms about the lack of diversity within the vaccine trials, that they did not reflect enough of what the American population really looks like. I'm wondering how dangerous that is, and if there's any medical implications that come along with that lack of diversity.
For the existing vaccines that are currently out there, the diversity is not an issue from my perspective. The safety trials are very well done. And I, for one, will be, like I mentioned earlier, up for the vaccination tomorrow. So I think as a reassurance to our communities, the Black, Latinx, and Native American communities, it's important that we stand strong and say that this is safe. This is important. And this is vital in order for us to deal with the pandemic.
So, Kristin, organizations have been trying to change the dynamics around race and healthcare for years, decades. How do we achieve greater social justice in healthcare delivery? And I know you're trying to do something different here. You want to leverage, tech and data, but sometimes you say you don't want to reinvent the wheel, but almost like, do we need to reinvent the wheel? Do we need to do something big? People have talked about like reparations. Should there be reparations in healthcare? How big are you guys thinking?
Look, we need to think as big as we possibly can. Having worked for years in private industry and with life sciences companies, and Benson also has worked in the health system, one of the things that you see is that what gets measured and paid for is what gets done. And that goes everywhere from investment in drugs for cancer, where you typically see good reimbursement. You see a lot more people competing for residencies in specialty medicine as opposed to primary care. And you see it in the way insurance benefits are designed, sort of specifically to identify and find the lower cost patients. So we're taking a similar approach with the Preparedness and Treatment Equity Coalition, where there is a movement towards paying for outcomes, paying for value in healthcare, but there's no measurement for equity. You can get your performance bonuses by having a drug that performs well on average, or by achieving vaccination rates on average within a population, or blood pressure control on average. But there's no incentive for making the difference between the worst performing patient and the best performing patient lower. In fact, you could achieve your performance bonus by selecting patients who are easier to treat. And there's no incremental reimbursement or financial incentives for spending an extra 20 minutes talking to a person who might be vaccine hesitant, or finding the right communicator for them. So we're going to elevate this through discussion and by funding research that would say, what would a health equity measure look like? We're already capturing data through electronic health records, through prescription claims, through health claims that could potentially demonstrate whether care is equitable and not just improving population health on average. And we need to see the medical community, economists, and data providers come together and develop better measures for equity, not just performance.
So, Dr. Hsu, Kristin just said what gets measured and paid for gets done. And you work in a community in South Dakota with the Native American population. Historically, tribal healthcare has been massively underfunded. How do we fix this? Is this a federal government issue? You guys are partnering, and you have members that are, big Fortune 500 companies, right? You've got J&J and Pfizer on this list. Is this a business needs to step in here and solve this? Who does it?
Everybody. I really appreciate the idea of thinking big, and I think it starts from ground level, talking with the patients and the communities, understanding their needs better. A lot of these mandates have come from federal government and state government, and often without a clear input, at least in with the communities that I live in, of what the actual needs are. So our coalition is really trying to bring in as many as possible, and not just say this is a federal mandate, not just to say that this is a large corporation mandate or a business mandate, but to create a coalition of all parties and bring ideas together, maybe ways that we haven't thought about before. The idea of going under value-based care and promoting quality, it was a really strong move in the healthcare industry in the last 20 years in the way that we deliver healthcare. However, like some metrics are out there, it created some unintended consequences in creating some disparities. And our goal is to create coalitions to address that disparities by looking at things in a different way. We think metrics and reimbursement is the right approach, but we're also having conversations with a lot of parties to make sure and validate that this is the right approach. And maybe there's others out there as well.
Kristin, we have about a minute left here with you. I'm wondering, when we talk about healthcare, we talk a lot about increasing access to healthcare, but I'm wondering how much we need to talk about increasing the quality of that healthcare itself, and if increasing the number of Black and minority doctors is paramount to that.
That's certainly part of it, but we also have a lot of great treatments that are underused. We have tests that are underused. We see lower rates of referrals to specialists for minority patients. So there's good quality care out there. It's just not necessarily getting to the people who need it most. And again, part of what we're doing is we're not measuring who's getting the right care and rewarding physicians for spending that extra time, or drug companies or pharmacists or drug distributors for achieving greater equity.
All right, Dr. Benson Shu, Kirsten Axelsen from Preparedness and Treatment Equity Coalition, thank you both for joining us today.
Thank you.
Thank you.